Good afternoon, ladies and gentlemen. It's my great pleasure to welcome you to a really very exciting lunch symposium sponsored by Rayner. And we're going to hear and learn something about a new, not really that new lens, an intraocular lens, so-called plus IOL. And we have a really exciting panel here as well. Welcome. Thank you for taking your time. It's just right beside me, Claudette, Abela Formanek from Vienna, the so-called AKH Vienna. She's going to give us an insight on her experience with the toric IOL of the Rayner, RayOne EMV Toric intraocular lens. And then next to Claudette, we have Masara Laginaf from the UK, from London. She's going to talk about a very interesting comparative study on the RayOne EMV in comparison to the typical EDOF Vivity lens from Alcon. I'm really looking forward to hearing your results. And last but not least, from Poland, Andrzej, that's correct? Andrzej Dmitriew from Poland. He's going to introduce a very important for him in future, getting even more important PROMs, patient-related outcome measurement platform, the RayPro from Rayner. And I think this is a really great opportunity for us to see your results and how you deal with this new kind of patient care. So, let's start. I was told to give just a short introduction. Professor Abela Formanek is head of the clinic for cataract and refractive surgery and day clinic for ophthalmology and optometry in the Medical University of Vienna. She is not only specialized in cataract surgery, but also in retina. But today we're going to talk about cataract surgery. And she's going to give us a talk on navigating precision, insights into rotational stability with the RayOne EMV Toric.
Hi, hello. It's a pleasure for me to be here, and I thank Rayner for inviting me to speak over here at the symposium. So I'll be presenting a case series of patients with cataract and astigmatism and the implantation of the RayOne EMV Toric. So the increasing demand for spectacle-free independence in all distances has encouraged the production of a presbyopia controlling lenses or limiting lenses. And we know that when you implant lenses for presbyopia correcting lenses, you have to correct also the astigmatism. We know that about 30% of the population, of the general cataract population, have got 1 to over 1 diopter of astigmatism. And when we implant presbyopia correcting lenses, we need to correct the toric with a toric lens. So the advantage of implanting a monofocal enhanced lens is that we try to bypass all the negative side effects of implanting a multifocal lens. The multifocal lenses are capable of correcting visual acuity at different distances, but there's a downside to the multifocal lenses because many people have dysphotopsias and a decrease in contrast sensitivity. So how does the RayOne EMV work? It's got an aspheric anterior surface, and it has a unique center region, which induces a controlled positive spherical aberration, and that is actually the effect of the extended depth of vision. It is a non-diffractive lens, which is good against dysphotopsias as compared to diffractive optics. So the patented RayOne EMV positive spherical aberration design works together with the natural positive spherical aberration of the cornea to achieve about 1.5 diopters of enhanced vision between the distance and intermediate vision. So we included patients with cataract without any other ocular pathologies. We performed anterior segment OCT to measure astigmatism or total corneal astigmatism. We used the KZR2 of TOMI and the CSO MS39, And we use the K values of the opticals of the CSO MS39 because it has an optical zone of 4.5 millimeters. We also did the barometry with the IOL Master 700, and we introduced these results in the ray trace calculator online. So post-operatively, we looked at the IOL decentration, tilt, and rotation using the Acacia at 1 hour, 1 week, 1 month, and 6 months. And post-operatively, we did the visual acuity tests at distance, intermediate, and near at 1 week, 1 month, and 6 months. This is just to show you what we did. We make sure when we do the pre-operative measurements that the patients, when they're on the chin rest, that their pupils are in the same lines just by shifting the equipment left to right, and you make sure that the patients are really sitting properly in the chin rest, and like that we get reproducible results. And these are the results at 1 hour, 1 week, and 1 month of one patient, where you can see that with the infrared image we can see the markings of the lens, and we interpolate a line between these two markings and read the axis of the lens. So in this way, we were able to do a very easy control, which can be done in any clinical setting, of the rotation of the lens. So the lens, we operate from the temporal side, and we operate at the 0 degree axis. The lens is placed in the capsular bag, and it's very important to ensure that you have a circular capsular axis with an overlapping circular capsular axis, and that you remove the viscoelastic from behind the lens to ensure that the lens does not rotate post-operatively. To mark the axis, we use the Callisto system, where we compare the image preoperatively, which was made with the biometer, with the IOL Master 700, and compare it to the vasculature image of the Callisto intraoperatively. And that's the way we achieve our axis. So coming to the results, we had 31 eyes, where 22 eyes were binocular results, and they were average results, just like in any cataract patient group of patients. The pre-op refraction, cylinder refraction, was at 2.29 diopters, and the pre-op corneal astigmatism was also at around 2 diopters, between 1 and 3 cylinder diopters. The post-operative spherical equivalent at 6 months was at minus 0.5 spheres, or diopter spheres, and the residual cylinder was at 0.42 diopters at a range of 0 to 1.25. This is just an example of a patient who was operated binocularly, a highly myopic patient with high astigmatism, and when you look at the bottom line, you can see that the binocular uncorrected visual acuity was at 0.8, and the intermediate visual acuity was also at 0.8, which is actually very good for somebody who was very myopic and with a high astigmatism. And the near vision was at Jaeger 1. Now coming to the cylinder results, or the outcome, this is a double angle plot. On the left-hand side, you see the results before surgery, and you can see the wide spread of the cylinder diopters. And here, if you look here, this was the pre-op value before surgery and the mean absolute value after surgery. And we were at an average of a mean absolute of 0.5 diopters with a standard deviation of 0.28 diopters. After 6 months, we only had 21 eyes who turned up for follow-up, and the results were similar at 0.42 diopters with a standard deviation of 0.32. Looking at rotational stability, we compared the results target to 1 hour, and then we used the 1 hour result actually as the control to see if the lens has rotated or not. So looking at this column over here, we had a rotation of under 2 degrees between the 1 hour and the 1 month and 6 month results. And on the left-hand side, you see the results of each patient, and you can see that there's hardly any movement except in 2 patients. And the same goes for here. So this is the result after 1 hour to 1 week, 1 hour to 1 month, and 1 hour to 6 months. So the results are pretty good. It's all below 5 degrees. We know that the ISO norm for rotation is that 10% of the patients, 90% of the patients should be within 10 degrees and 95% of the patients should be 20 degrees. That's the ISO norm for toric lenses. These are the results of the residual refractive astigmatism, which we, of course, measured subjectively. This is the refraction. And we had 95% of the patients within 1 diopter of astigmatism and 81 patients within 0.5 diopters of astigmatism. These are the results of the first-in-eye results of the EMV Toric, where you can see that the results are pretty similar at below 1 diopter. We had better results within the 0.5 diopter, where they had 74%. The prediction error is the difference between our target refraction and what actually turned out after surgery. So 95% were within 1 diopter, 60% were within half a diopter, and about 40% were within a quarter of a diopter. These are comparable results to normal cataract patients with other lenses. So the visual acuity, we did the best corrected visual acuity at 1 month and at 6 months. And we also checked the uncorrected visual acuity at distance, intermediate, and near. And when we look at the results, we had 30 eyes after 1 month, where we had a logMAR of a distance at 0.15, and there we are. This is the best corrected visual acuity, and this is the uncorrected visual acuity at distance. And we had logMAR of 0.1, and at 6 months, it was practically the same. And binocularly, it was almost 0. And the Jaeger was actually very good. It was somewhere between 2.4 and around 2.4 and 2, which means that the reading capability was actually better than reading newspaper. And the intermediate was also just as good. And on the left, you can see that's in decimal, so it's maybe depending how you prefer to see visual acuity tests. Tilt and decentration, the tilt was within 5 degrees. That's also very good. A tilt above 10 degrees would cause clinical relevance, and the patients would have a higher astigmatism. And when we look at decentration, here we have 0.2 millimeters. It's very stable. The lens doesn't decentrate very much, which are also very good results. These are the plots of the individual patients for tilt and decentration, and you can see most of them remain pretty stable. And here we are again, the lens decentration in millimeters. There's a very nice publication where 5,000 eyes were included after cataract surgery and the implantation of a toric lens. These are real-world data, and 27%, there was, this is actually very interesting, the difference vector between the targeted and the calculated residual astigmatism was 0.8 diopters, and the main source of error was the preoperative measurement of the cornea. So it's very important when you're doing measurements for toric lenses to use different biometers and keratometers and topographs to measure the toric and to make sure that the patients are really sitting properly in the chin rest and that the pupils are in line. And of course, the intraoperative IOL misalignment, it depends what method you use, how exact you are with marking your limbus to implant the lens. So these are the most important things to do when you want to have better precision in the implantation of toric lenses. So in summary, the patients were very satisfied. We had a significant cylinder reduction. We had it has a very high rotational stability, and we did not have to rotate any lenses. We had a predictable refractive accuracy, and the uncorrected distance visual acuity was similar to that of a standard monofocal IOL. The range of vision extension with excellent uncorrected intermediate visual acuity, and we also had a very good functional uncorrected near visual acuity. So, take-home message for the implantation of this lens and any toric lens in effect is to have a very careful pre-op screening and patient selection, and it's very important to have very reliable measurements before surgery and to perform meticulous cataract surgery with a small clear corneal incision, capsulorhexis, overlap, and removal of viscoelastic. And we also tell our patients to remain relatively quiet after surgery, and they should not read for about a week so that we avoid the saccadic movements of the eye. And we check the position of the lens after about 2 weeks. And we do a refinement of the position only when it's over 10 degrees, when there's rotation of over 10 degrees, and when the patient also has subjective problems. Otherwise, we do not actually re-rotate the lens. So thank you for your attention.
Thank you, Claudette, for this excellent talk, presenting your wonderful data. We're going to have a panel discussion at the end of the session. However, if you'd like to ask Claudette now a question concerning her talk, just feel free. If not, I would have a question for you. You had a really excellent uncorrected intermediate visual acuity, but you didn't use the monovision concept, did you? Or did I miss it?
We did monovision. Yes, what we did was we implanted the first eye normally at about the first minus, and then the second eye at half a diopter away from that, more myopic. But we also took into consideration the needs of the patients. So if patients rather had more distance, we implanted both eyes with distance. So this is not a mini monovision concept. We practically operated how the patients need to, what kind of, what they do, how old they are, whether they're reactive or more sedentary. And, but the main attitude towards implantation of the lens and the refraction, the target refraction is minus 0.25 for the first eye.
Minus 0.25. 25.
Right, and then the second eye would be minus 0.5 or minus 0.75.
And you have not been doing same-day procedures?
Yes, we have. But the binocular eyes are same-day procedures.
Same-day procedures,
yeah.
Okay. In all eyes or just in?
No, we had 11 patients with binocular, and the rest were monocular.
Okay. Any questions? Okay, thank you so much.
Thank you.
We proceed to Dr. Masara Laginaf. She's a double fellowship trained consultant ophthalmic surgeon based at the OCL Vision in London. She is specialized in cornea, cataract, and refractive surgery, providing bespoke solutions including laser, ICL, and premium IOL technology. She's a surgical trainer and examiner for the Royal College of Ophthalmologists and an ESCRS video competition winner. Thank you so much for sharing your data.
Thank you.
So, and actually, I'm really happy to listen to your talk because we're going to hear a comparison of the RayOne EMV and the Vivity. Comparing visual outcomes and patient satisfaction.
Thank you. Thank you for the kind introduction, and thank you to Rayner for having me speak today. So I'm going to talk today about the RayOne EMV versus Vivity study that we carried out at OCL Vision in London, UK, comparing the visual outcomes and patient satisfaction. So I just wanted to talk a little bit about our story specifically. So in July 2020, we implanted the first ever RayOne EMV lens in the world. Please let me know if that is not correct, anyone from Rayner. But to our knowledge, it was, and that was performed by my mentor, Alan Barsom, who was a founding director of our clinic. So believe it or not, this lens has been in use for over 3 years now. And my journey started with collecting that early data and presenting the first real-world outcomes in the CRST Rayner supplement in 2021. I then started my own private practice in September 2022, and the first premium lens that I implanted was indeed the EMV lens, closely followed by the Toric EMV. So we have a wealth of knowledge and information regarding the lens. And one of the things people were interested in is EMV versus Vivity. That's a topic of conversation that seemed to come up time and time again. So we decided to carry out a retrospective 6-month follow-up study comparing the EMV lens with the Acrosoft IQ Vivity lens. This was a monocentric comparative study looking at bilateral implantations. We looked at the objective assessments, so the VA and refractive outcomes, but also the subjective outcomes, so the RayPro questionnaire and software, to ascertain patient satisfaction rates. We had approximately 300 eyes per group, and the mean age was 70 years old. So looking at the investigated IOL design, we know that the RayOne EMV induces a small amount of positive spherical aberration. It has no zones or diffractive technology within the lens, and it is very well tolerated by patients. The Vivity lens works slightly differently by inducing a small amount of negative spherical aberration, and it has a central elevation that elongates the wavelength and increases depth of focus. This slide, courtesy of Damien Gatinel, highlights the work done by Dr. Benjamin Stern and Damien, looking at the performance and optical design of the lens using the Nemo tempo. And they found that the Vivity IOL showed a wider, possibly diffractive step, which was in line with that in vivo magnification of the optic under the microscope. And so there may be some diffractive element to how this lens works. Professor Findle showed the halo size was significantly smaller with the EMV lens versus the Vivity lens, and this is likely also due to the lens design. So looking at our study, the demographics, we had around 300 eyes per group with a mean age of 70 years old. The IOL power ranged from 10 to 30 diopters. And we had an IOL cylinder for our toric IOLs of around 1.5 diopters. The delta K was on average less than 1 diopter for both groups. For the toric lenses, we implanted bilateral toric EMV lenses in 84 eyes in the EMV group and 126 eyes in the Vivity group. The majority of our patients, as you can see, have astigmatism between -0.5 and -1.5. And we're quite a refractive heavy practice, so we do tend to have a low tolerance for implanting toric lenses. Most eyes were targeted for emmetropia, so over 60% in both groups. And approximately 10% more eyes in the Vivity group were targeted for somewhere between -0.75 and -1. And that's probably because in the Vivity group, we were trying to achieve more spectacle independence, hence the use of an EDOF lens. Looking at our refractive accuracy, so both lenses actually performed really well with over 70% of patients or eyes achieving within half a diopter of refractive spherical equivalent target, and almost all patients within 1 diopter, which is better than the UK benchmark. Now let's come on to the visual acuity outcomes. So I'm going to present the binocular visual acuity outcomes. And the first group was both eyes targeted for plano or emmetropia. And as you can see, the uncorrected distance visual acuity in both groups was excellent, but the p-value shows that the EMV group was statistically significantly better for uncorrected distance visual acuity. The near visual acuity in the Vivity group was statistically significantly better by about 1 line of vision, and the intermediate vision was equivalent in both groups. Now we come on to mini monovision, so looking at the dominant eye for plano and the non-dominant eye for -0.25 to -0.5 diopters. What we see here is that the uncorrected distance visual acuity remains better in the EMV group by about half a line, and that is statistically significant. The intermediate vision is much the same between the two groups, very excellent intermediate vision. And the near visual acuity in the Vivity group is still significantly better by about a line of vision, which you would expect with the EDOF lens design. What's interesting now is we come on to the moderate monovision offset, so the dominant eye for plano and the non-dominant eye for between -0.5 to -1 diopters. And what's interesting here is you still have that maintenance of the excellent uncorrected distance visual acuity in both groups, statistically significantly better in the EMV group. Intermediate vision, again, is very similar between the two groups. But when you look at the uncorrected near visual acuity, you start to see that the performance of the EMV, when you target a little bit more myopia, you start to lose the statistical significance that you saw with the Vivity lens. So the near vision is equivalent to the Vivity lens now. So with a modest monovision up to -1 diopters with the EMV lens, you're able to achieve a similar level of uncorrected near visual acuity to the Vivity lens, but you're still maintaining that statistically significant superior uncorrected distance visual acuity. And that's a really interesting finding. Looking now at the outcomes of the toric IOLs, more eyes in the RayOne EMV group had a postoperative refractive cylinder of 0.25 diopters or less, so that's 61% versus 46%. But overall, the outcomes of both lenses were very good, with 91% of eyes in the EMV group achieving less than 0.75 diopters of CIL and 86% in the Vivity group. Now we come on to the subjective patient-reported outcome measures. So we asked our patients to rate their satisfaction rate with the surgery, and we sent this to 300 patients who had binocularly implanted EMV versus Vivity. And we had a response rate of just under 42%, with the EMV satisfaction rate pipping Vivity to the post with 84% satisfaction versus 78%. So the conclusions of the study were that the RayOne EMV demonstrated a statistically significant better binocular uncorrected distance visual acuity. The binocular intermediate visual acuity was excellent in both groups and was equivalent to that achieved. EMV versus Vivity was very much the same. There was a very good level of uncorrected near visual acuity in the EMV group, but slightly better in the Vivity group, particularly for emmetropic aim or mini monovision aim. And that is to be expected considering the positioning of the lens as an EDOF lens. However, when you had a monovision offset of up to -1 diopter, that resulted in the binocular uncorrected near visual acuity of the EMV closely matching that of the Vivity group. There was more effective postoperative cylinder reduction in the EMV Toric group, with 61% of eyes achieving a postoperative refractive cylinder of less than 0.25 versus 46% in the Vivity group. There was a higher patient satisfaction rate in the EMV group, and I describe this as my headache-free IOL. So future considerations, it would be very useful to perform a targeted subgroup analysis, really comparing like for like with specific comparisons of exact refractive targets. It would be interesting to investigate a higher level of monovision to see whether you can achieve greater levels of near vision with the EMV lens versus Vivity lens. Further RayPro questionnaire results comparing the refractive subgroups and more advanced IOL technologies, and performing a cost-benefit analysis across different advanced technology IOL models. I would like to acknowledge the surgeons at OCL Vision who operated on these patients, the optometric team, and the R&D team who were pivotal in the success of this study. Thank you very much.
Thank you very much, Masara. Great results. Any questions from the audience?
I got one question.
Yeah, of course.
When you increased the monovision, did you only do it in the EMV group, and with the Vivity group you stayed on plano, or did you also go from monovision there?
So both groups were like for like. So the dominant eye was always targeted for plano, and the non-dominant eye in that moderate monovision group, it ranged from 0.51 to -1, but really the majority of patients were over -0.6 diopters. And the majority of those groups were somewhere between -0.75 and -1, but it was very much the same in both groups. Yes. So it really was like for like, but doing a more targeted subgroup analysis would give us more information.
So when you increased the monovision in the Rayner group, you
Yes.
also increased it in the Vivity group. This was the question, I suppose. You know what I mean? That you're comparing Abela and yeah.
We compared the range. Yes, so -0.51 to -1. We compared those two groups.
What's supposed to say?
But what we would like to do is do a more targeted subgroup analysis to see if that's maintained.
I've also a question concerning your monovision concept. How you do it? Do you do same-day surgery like the Viennese group likes to do, or do you do one eye first? If you do one eye first, which eye do you do first? Do you do which one of the eyes do you do first?
So 60%, around 60% of our patients are binocular simultaneous same-day surgery. And 40% roughly were staggered, and it really depended on which eye had the worst cataract or which eye they wanted us to do first. It was very rarely a choice based on targeting plano or targeting myopia. Sometimes in patients who'd had laser refractive surgery, we may target the non-dom eye for myopia first.
This was actually my
for
question.
increased accuracy, and then the dom eye.
And then
really
you take the information from the first eye. And,
Yes.
Okay.
Yes, exactly.
As we've learned, you have the positive spherical aberration, which is the concept of the RayOne EMV, which increases the depth of focus. From this concept, we would expect that if we have intraocular lenses with high diopters, there must be even more advanced effect.
Yes.
So what I would be interested in is, did you invest in those patients who were hyperopic with higher intraocular lenses in comparison to the myopic patients? Do you see an additional advantage in those patients?
We haven't studied it, but that's a really interesting area to explore, definitely. Something for the future.
Thank you.
Thank you.
Any questions? Comments? Thank you so much.
Thank you. Thank you very
Going
much.
to proceed, and now we go to Poland, Poznan. And I have the pleasure to introduce Andrzej Dmitriew. He's an ophthalmologist, senior consultant, academic teacher, and anti-segment surgeon at the Department of Ophthalmology, Poznan University of the Medical Science, Poland, since 2003. And he told me not to continue now, but I think it's
Thank you so much.
just worth it. He's a medical doctor, founder and co-owner of a private practice, private clinic, the Reoptis in St. Albert Hospital in Poznan. And I think that's the reason why you really have very interest in the next topic we're talking about, because having a private setting, we want to have very happy patients. And this is what you're going to talk about. It's the patient-centric practice, harnessing PROMs, patient-rated outcome measurements for optimal ophthalmic care. Thank you.
Thank you so much for this kind introduction, and thank you to Rayner for the invitation to speak today. It is really a matter of choices. And in case of being a medical director and someone who needs to form the portfolio of a clinic, sometimes it's not easy to make choices, and they are based on clinical studies. And I was delighted to see the studies within the last two presentations, because this is actually the field where we are working right now. And without the clinical data, you cannot actually assess the needs of your patients. But I'll try to convince you that it's not just clinical data which you need the input from the patient as well. So if you were present during the autumn ESCRS last year, you probably had a chance to listen to Professor Graham Barrett. And I think that this sentence gives you a lot of inputs regarding what can be achieved and what results in best satisfaction of the patient, with potential least compromises, which is very important where you consider forming the portfolio of your clinic. So obviously, when you get started and you develop your practice, it's so important to know what would be the lowest level of the IOL which is offered and the highest level. And it's so important to understand the needs of patients then, and that is why we see EMV as a lens with extremely high potential in every part of this portfolio. Then, by selecting patients and selecting offsets, selecting monovision, we're trying to play a little bit more. We're trying to squeeze a little bit the lens to get more uncorrected vision from that. And finally, if you want to see what your patients consider regarding the outcomes, you need to find a reasonable way of assessing the patient needs and assessing the outcome of your surgery. And I think RayPro, and I'll try to convince you that RayPro is a perfect system to do that. So when you get started and you're developing your practice with any type of the lens, it's so important to understand which group of patients are you targeting. And basically right now we're confused by different groups of lenses, by the companies which are giving specific names, like EDOF became a gold standard of the name, but it doesn't always mean the same. So we know that within EDOF group, we have monofocal plus lenses, we have lenses which are diffractive, which shouldn't be a part of this group actually. But that is even more confusing for the surgeons trying to select the IOL spectrum. And so we had exactly the same issue, and I think many of you have the same issue when you're trying to consider which lenses should be taken into consideration when you're doing this. So in our part of Europe, unfortunately, when it comes to reimbursed surgery, the lowest quality hydrophilic lenses, I mean the lenses which don't origin from EU or US, sometimes are reaching even 50 or 60% of the market, and that's a big problem when it comes to the quality. So I called it Econo. Then we had a classic hydrophilic white lens from reasonable manufacturers. Then we have a monofocal premium lens from the best companies which we know, and where the quality is acknowledged. Then finally, we consider that theoretically, when it comes to the value, hydrophobic material gives a little bit more clinical advantage, and we still question the yellow filters. We still don't know whether there's a real clinical benefit, but it was considered by many to be like a standard plus. So as you see, you have 4 different choices within the portfolio, and you haven't even started considering the extending range of vision. And then you realize that then you have groups of lenses which actually give you more optical quality, and these are monofocal plus and EDOF lenses. So if you ask your doctors or if you ask your optometrists to inform the patients that you have so many different choices, I don't really believe that anyone of the staff would use them. It's impossible to do that. So I considered that before, and I thought that actually forming a portfolio between a monofocal premium, so high quality monofocal lens, and a premium package, which is either EDOF or a monofocal lens, is reasonable, and it's much easier to make choices then. And we actually had it until September last year. But starting with this choice of monofocal, high quality monofocal lens and EDOF or multifocal lens, I think it's not enough, because we see how market changed within the last years. We see that the lenses with extremely high quality of optics, in case of EMV using positive aberrations, completely redefined our practice, and we must find a place for this group of lenses within the portfolio. So that's the main reason why we thought that the monofocal plus, or the lenses with extended range of vision, which are theoretically based on monofocal platform, are a reasonable solution for the standard of the surgery. And you still have EDOF and multifocal lenses, and I think the reasonable solution can be taken between these two. And that's why I made a decision in October that we stopped offering any monofocal IOLs since that moment, and we don't offer them anymore. I don't find any reason why we should still offer monofocal lenses if we have so many studies convincing us that the quality of distant vision, even in low light conditions, is exactly the same. So generally, when you look at it, you think that considering different types of optical approach towards extending the range of vision is really confusing for so many of us. That is why selecting specific patients and selecting specific offsets is so important. And I was so delighted to see the different groups of mini monovision, which were mentioned in Masara's presentation, because you can actually see that playing with monovision gives you much more spectacular independence when it comes to certain lenses. So obviously, you can still be very conservative and start with emmetropia in both eyes. And no one says you push towards monovision. If you're comfortable with that and your patients are comfortable, why wouldn't you use emmetropia in both eyes? But we're trying to make use of the optical properties, and that is why in my clinic, the mini monovision is a standard of care, which is at least like 80% of patients. And at the same time, as we're operating 80% or even more of patients both eyes same day, it means that we need to plan the refraction, we need to plan the postoperative vision, and it's based on patient needs. And that is why we pre-select the level of monovision for each group of lenses and each group of patients. And it needs to be done actually taking into account patient needs. So just to very briefly clarify the ranges of monovision, because sometimes it's very confusing. What does it really mean to have a mini or micro monovision? I think when it comes to micro monovision, it's pretty clear, because it's extremely well tolerated by patients, and we all agree that 0.5 diopter between the eyes is something what is really the easiest way of starting with monovision. But obviously, when you're trying to extend it, when you're trying to increase the offset or go towards mini monovision, like levels of 0.75, 1 diopter, it changes a lot in your practice, because first of all, you need to train your staff, you need to see the outcomes from your patients, and I guess getting step by step is very important. And that is why we never try to start with any lens without trying the lowest levels of monovision first. So generally, we're trying to position specific lenses. We're trying to collect all the information we have before the surgery. But does it really mean we're right? We don't know that until we see the outcomes. And there's always a question whether we are getting true statements from the patients when you see them during follow-up visits. And I think the RayPro system was the best setting for us to assess the patient needs and finally what we achieved after surgery. So just a couple of main information regarding the RayPro system. If you're a Rayner IOL user, it's free for you. So you're able to use the long-term, real-time monitoring system for patient-reported insights. And you can actually assess different types of lenses and different types of expectations and see the outcomes of specific groups. And if you're really willing to change your practice towards using patient-reported outcome measurement, you will briefly see that actually your practice is becoming a gold standard in something what we could call a patient-oriented practice management. So we're not trying to do what we thought is the best solution. We're trying to see what is the satisfaction rate, what is the satisfaction level of our patient, and then decide what was really the best solution for us. Obviously, clinical trials tell us a lot, but these are just numbers. They don't tell us that much about the actual quality of life. So when it comes to the collection of data and when you're trying to compare different types of lenses within your hospital or practice, it makes your life so much easier because sometimes we predict the outcomes. We think that one of the lenses is better than the other one. But sometimes it can be very surprising for us to see that after you see the comparison, it's definitely different from what you saw and what you expected. So how does it work? So we're starting at the level of 1 week. It's very easy to add patients to the RayPro system. You can actually use batches of patients to make it easier for your clinic. And then the next visit would be after 1 month, 3 months, 1 year, and 2 and 3 years. Actually, these are just patient-reported information, which we analyze afterwards, and we can easily access to the statistics of what the patient is deciding to tell us. So I think that's one of the most important outcomes of the system. And I was very interested to see this data because I'm both the user of EMV and Microsoft IQ Vivity in the same way as Masara is using them. And it's sometimes the prediction of potential outcomes which is on our side. And sometimes it's the real clinical outcomes which we see on patient side. So as you see, the numbers are really high. So in terms of the total responses, it's close to 5,000. And these are the data at 3 months. And you can see RayOne EMV, you can see Microsoft IQ Vivity, and on the right-hand side, you can see the TACNIS iHands. The overall satisfaction rate is very similar in both Vivity and EMV group, which is quite surprising. And it's much better than the iHands group. So actually, you can see that the balance between EDOF and the monofocal lens with extended depth of focus is exactly the same level. And when you compare the distance, intermediate, and near values, they are not so differentiated between these two lenses, which gives you another question in your head, whether it's just the quality of lens or it's the instruments we used to form the range of uncorrected vision. And I think what we see here is that the actual modification of mini or micro monovision tells you a lot about what we can do to push the near vision, uncorrected near vision, especially in the EMV group, which basically at the level of 1 diopter makes it very similar to the outcomes of Vivity lens. So to understand the difference between IOL-oriented or surgeon-oriented practice and patient-oriented practice, I think that's something what tells us a lot about the RayPro system. So we have lots of advantages in monitoring patients. We can easily manage patient expectations because they can actually acknowledge us if they have real problems. And finally, it's much, much easier for me as someone who is managing the practice to see the real outcomes of specific surgeons, see how well they did, and whether we are really reaching the level which we plan to have. And finally, just to conclude, I think it's so important to try to simplify the selection process for the patient, to simplify it for the surgeon, so that it's much easier when it comes to the conversation regarding the potential outcomes, then to utilize the offsets depending on the solution which you have and depending on the optical properties of the lens, how flexible it is with these solutions, and finally, instead of having the surgeon-oriented or clinic-oriented practice, change it into patient-oriented or patient outcome-centric clinic. Thank you so much for your attention. I really hope we'll try to use the information coming from patients and their quality of life more often after we see so many new optical properties within our portfolio.
Thanks a lot, Andrzej. It was a great talk, and I'm sure pretty much all of you sitting in the audience is now convinced of the Ray Pro, and I believe it's a really win-win situation because the patient definitely feels better cared for. On the one hand, the doctor learns more about his outcomes, but not only the refractive outcomes, but also the functional vision outcomes. And third, you learn about the percentage of your patient satisfaction, and this can be used definitely for advertisement. Is this what?
Yes, because
what summarizes
obviously,
it?
when you consider managing a private clinic, you need to consider marketing as well. And if you know the outcomes and if you know the problems which actually your patients have, it's much easier then to plan the material, the IOLs, and the conversation which is used to acknowledge the solution to the patient. So I think it's even more important for us, who are managing the staff, to know whether we did a good job during the initial process.
And do you know how long does it take the patients? To ask another way, how many of your patients, you give them the opportunity to use RayPro, what's the percentage of the patients using this tool?
So I was delighted to see in Masara's presentation that you have 41%, right? And so we saw a pretty interesting pattern that generally younger patients are more likely to respond. But when it comes to like 80+ patients coming with their families, they're extremely likely to share their opinion. So they're even very happy to do that. And probably many of us would consider that they're willing to tell us negative things, which is not the case. Because they want to say, I like what I have. I'm very happy with the solution. I'm very happy with the range of vision I have, and I'm very happy with the quality of life.
Sorry, any questions from the audience, from the panel?
So I just want to ask, so the patients fill in this app when they're at your practice? They don't do it from home, is this right?
Yeah, because they get an invitation through the email address, and then it's very easy to go step by step.
But you know, not to do it at home. They have to do it at home because it's a follow-up of, I think, how many years? 2 or 3 years?
That's after a long time, up to 3 years.
Is it app-based or is it
website-based?
Website-based. Okay. And how long does it take?
For each, I guess it's very different from patient to patient, but they usually say it's very reasonable time. So it takes a little bit more for the older group, and they usually say it's like playing with the form itself. But generally, I think it's very user-friendly and very easy for them.
Any questions?
So the compliance, well, if they're doing it from home, how do you know they're going to be compliant? How do you remind them to fill it in?
Oh, the system does it.
Yes, the system reminds them to do
it. So you cannot have any obligation or push them to do that, right? Obviously, and it's their will to cooperate.
So what's your compliance? How many % of the patients actually fill it in?
As I mentioned, I don't really have like age range percentage data here, but what I saw from Masara's presentation, there was 41. And I wouldn't be surprised if it's quite similar for a majority of patients, but you can really see differences in different age groups.
Do you believe in incentivization for PROMs? So, every month there'll be a draw for a prize, if you complete this, just like when you complete any questionnaire, or donations to charity for every survey received.
That's another mechanism which we can consider because actually when you analyze it and you see who's the most interested side in the whole process, it's us, because we're interested in seeing our own results, right? And we're not interested in seeing the Snellen visual acuity at the end, because that's just one parameter, but we're interested in patient quality of life. So I think considering solutions which would be more comfortable for the patient, like considering charity or any other instrument, like if you submit all 5 steps, you can consider like free consultation, whatever else, right? That's one of the mechanisms you can consider then.
I think we are convinced, because on the other hand, there's no disadvantage using RayPro, isn't it?
Yeah.
So, okay, so we can change the topic now. And you made a very interesting comment during your talk, that you said you no monofocal IOL anymore.
Yeah.
So what is your experience in patients having advanced AMD glaucoma cases? Would you also go for a monofocal plus lens?
Yeah, I'm still using EMV then.
Why?
Why shouldn't I? Because we analyzed so many studies, and right now we have so many head-to-head studies comparing not just monofocals and monofocal plus lenses, but at the same time, it's not just your study comparing Vivity and EMV. We have from Jonathan Moore, we have from Oliver Findel, and we really know how to position specific lenses. And when it comes to distant visual acuity and quality of vision, then we know there's no compromise.
Do you think this just counts for the RayOne, but or also for the competitor?
I'm using
Careful.
yeah, I'm using EMV as a majority of lenses in this group. I have some experience with high hands. So that's one of the reasons why we changed this pattern.
Because
right?
the big difference is the one is hydrophilic, the other hydrophobic. So it's the only
that's
one.
A question of material.
There's only one indication where it might become a problem. This is something I would like to ask all of you. Have you used it in Fuchs endothelial dystrophy cases? Because this is what I usually don't do, to use hydrophilic lenses there, because we have seen IOL opacifications after that.
We have a group of patients with Fuchs dystrophy where we use it.
No problem at all.
No, not yet.
Have any of them needed DMEC?
Pardon?
Have any of them needed a DMEC?
No.
Not yet?
No.
Okay.
No, this is what I was talking about, because if you do a DMEC, and you put it in an air bubble, you have the risk of getting IOL opacification. And it would be interesting for me to know whether this is the same problem as it has been described in other IOLs. Would you be careful to use it in DMEC cases?
Yeah, as a DMEC surgeon, I wouldn't use a hydrophilic lens in a
theoretically, if it's a high risk of corneal transplant, then that's another story. Right?
Yeah.
So you guys, you agree this would be the only contraindication for?
I tend to give patients what they want, what they ask for. If they've got mild AMD and they're very motivated to try and achieve some spectacle independence, then I'll go. Then I will consider the lens, but I won't give them what they don't ask for. So if they just want their cataract removed, improved quality of vision, and they're very happy to wear glasses, I'll give them a monofocal still. I'm quite conservative like that. Yeah.
So that's surprising.
I'd like to change the topic a little bit, because the advantage of this lens is due to the increased depth of focus that if we do monovision and we're not on point, this doesn't make that harm. So what I would be interested, actually, just to include you all, who is doing same-day surgery? Hands up. The rest is doing it first one eye and then the second eye. Which eye do you do first? The near distance or the distance? Can you explain why? Yeah. Okay, I understand. Okay.
The other thing.
The idea is that this depends. So if you're exact on 0.0 after your first eye, then it's perfect. Then I understand your idea. But what about if you're at plus 0, half a diopter into? This is what I wanted to discuss and wanted to hear.
That's what Graham Barrett does. He likes to do the dominant eye first, put a trial frame on, put a 1 diopter lens in to show them what they could achieve in the non-dom eye for near vision. But then he'll get them to look into the distance, and they'll say, well, my distance vision's more blurred. He says, yes, but look what you're gaining for near. And that kind of gives them an insight as to what they'll achieve with that offset in the non-dom eye, which is another nice technique. So I think
So that's just your approach is with the monofocal plus lens reasonable because it's more forgiving. Your approach, targeting the distance eye first, is with the monofocal plus, I think, more realistic because as it's more forgiving, and even if you at the end have plus 0.5 diopter, the patient will have a very good visual acuity, distance visual acuity. If you do just a normal monofocal lens, then you get into troubles. Then the idea of doing the near dominant eye first, and you might end up in minus 1.0 or emmetropia, then you could react for the distance dominant eye. What is your approach? Distance first?
So in my case, I'm doing the non-dominant, and actually within the 20%, which I'm not operating on both eyes, there are lots of patients who actually don't have a cataract in the other eye. So they are still like 20/20 or 20/25 in the other eye. So we're always starting from, which is usually a non-dominant eye with a cataract, and we're doing that for near. And then obviously it's a little bit more clarification, but we always have that 15 to 20 minutes discussion with the patient with any solution, just to discuss it. So we never leave the patient without it. So. So I guess patients after hyperopic LASIK is one of the typical groups where using a negative aberration lens is a problem, right? So that's one of potential contraindications. But there are lots of smaller groups where we know that this patient would not be beneficial from an EDOF lens, and we actually consider a positive aberration monofocal with extended range just because we're just more confident in the outcomes.
It's like some patients have plus 20, plus 30, or the other ones 0 spherical aberrations, and so you're playing with positive spherical aberrations. Which are the ones who are performing better actually than others? Do you have experience in that, or is it, because
You mean based on aberrations only?
As I just pointed out before, I don't have, this was what I was asking you. We would expect an even better effect in patients with high diopter intraocular lens or hyperopic patients, because it's positive spherical aberration we're using in this monofocal plus lens. So I would expect if we have patients kind of 24 up to 30, it's like near vision, uncorrected near vision acuity.
Yes.
Zero,
pupil size as well. There's some pseudo-accommodation effect. People that have had previous refractive laser, especially myopic, they seem to get a bit more. Older patients, so 80 plus, they don't seem to get as good near vision as you would expect. Mild macular pathology. But younger patients, patients over between 50 and 70, they're achieving really good near vision. I'm not seeing a huge difference in different powers of the lens. The majority of patients I'm putting them into are around the 20 diopter range anyway. I'm very rarely putting them into the extremes, so I wouldn't have enough numbers to know. But it's a good question. Older patients, just to be a bit more conservative with your promise.
Maybe something you've got a huge patient group.
Yes, we could
maybe look at that.
dive into it.
Yeah,
Yeah.
you can check that maybe, because we've noticed that some patients really have good near vision, not even intermediate, just near vision, and some don't. So there must be some kind of, it's most probably the spherical aberration of the cornea, which is the reason.
And we don't do wavefront aberometry on everyone, so only if they've had previous LASIK or something.
Right.
Yeah, we don't have that. But
that might be
a good
an issue
question
to look at. Look into.
Coming back to Claudette's talk, in your daily practice, what degree of astigmatism do you tolerate, and when do you start using toric IOLs?
Above 1 diopter, depending on what kind of patients they are. Some patients say, they don't mind using. But especially if it's against the rule, of course, we correct, yeah. If it's with the rule, and we sometimes leave it, if it's like 1.2, you don't have to do that, you can leave it. But it's also a matter of what the patients do, how young they are, what they're up to. Some patients say they don't mind wearing glasses later on, so when you talk to them, they're...
Do you think it's even more important to use toric IOLs in monofocal plus lenses compared to monofocal lenses?
Yes, definitely. Yes, because the wish for spectacle independence is there. So all the more. I mean, if I'm going to put in this lens in the eye, then I'm aiming for spectacle independence. So yes, I would say even more than with monofocal. Yeah. With a normal patient who is normal cataract patient gets a normal monofocal lens, you're going to have glasses anyway. So
I would say I'm using torics in over 50% of patients. Yeah. Especially if it's the DOM eye. Yeah.
So in our case, we just make decisions based on the visual acuity. So if the uncorrected visual acuity is less than 2 lines, compromised by the residual astigmatism, then we make a decision, because sometimes it's like 0.5 diopter, sometimes it's 125, and they're still missing like half a line, right? So that depends on like what really is the difference between the uncorrected and corrected vision.
Question for you, Masara. Any reason for using an EDOF lens in your daily practice?
Yes. So I do a lot of RLA as well, refractive lens exchange, and if my patients are not tolerating so much of an offset between the 2 eyes and they want complete spectacle independence, so let's just say they're getting to 1 diopter and they're starting to feel it with a loose lens test over the non-DOM eye, then I would consider using an EDOF with a lower offset, maybe minus 0.75, to really guarantee.
But how do you know in advance whether it's going to tolerate the difference between the lenses?
So if they've got good vision in both eyes, refractive lens exchange, then we will do a loose lens test over the non-DOM eye.
How often do you do it?
Every patient.
Every patient, okay.
how long do they do that for?
We literally just put it over their eye and see how they feel, just that gut instinct. And then we see how much we can push and what level of vision they're able to achieve. And we very rarely do contact lens trials in our clinic. It's a great way of discharging patients and never seeing them again.
Yeah.
So we try to avoid that.
We are running out of time. Looks like a very interesting session.
Question.
Yeah.
You actually aim for 1.5 diopters offset in the monovision in EMF in your RayOne lenses, EMV lenses?
Usually -1.
-1.
If I want to achieve a spectacle independence, -1.
Is your distance vision compromised by doing that?
On average, it's around 0.3 logmar, 0.2 to 0.3 logmar, which is similar to Vivity, if not a little bit better, actually.
Still?
Yeah.
So thank you so much. We have to stop now. I think it's really very interesting. We have learned that the RayOne Toric is very stable in terms of astigmatism correction, no rotation at all. We have learned that it performs even better than a classic EDOF lens. And I would say we ought to go back home and use the Ray Pro for our patients now for their and our satisfaction. Thank you very much for being here.
Thank you.
Have a great time and safe, quick back home.